So thank you for your patience. And we're going to invite Dr. Lasky to come up. And I'm going to stop sharing this real quick. Tiffany? Okay, so we are going to escape out of this. Where's yours? Is this one yours? We just need to pull his up.
You good? Cool.
Or your pocket.
The other way. Oh, cool. Okay. I know my light won't show up, but probably have an arrow. Okay. Hello, everybody. Welcome. So my name is Joseph Lasky. I am a pediatric hematologist oncologist, and I am the medical director for Cure for the Kids Foundation, also known as C4K. And really what C4K is it's a pediatric multi-specialty clinic that takes care of kids with cancer, blood disorders, and a number of other chronic devastating childhood diseases. And I would say we're the only nonprofit pediatric clinic in the state of Nevada. And in fact, we're probably one of very few in the entire nation. And I'm very proud to be a part of that. And I think we do some great things. And we're really lucky to be a part of Roseman University here as well. So I grew up in Chicago, trained some there, and then due to some dislike of weather by my wife, we went to the West Coast and trained at UCLA. And then in 2017, I moved here and joined C4K, and this is where I am now. Oh, shit. Looks like I can move us. We can always do that. There we go. Now it's working. So just, Cure for the Kids Foundation, C4K, our mission is advancing cures and prevention of childhood cancer and other devastating childhood diseases through clinical excellence, research, and innovation. And our vision, as is up there, is to, ensure continuous quality improvement and being an efficient and responsive team that, we want to not just take care of the individual needs of the patient, but take care of all of their needs and help with the family as well. All right, so to get into childhood cancer, I'm going to talk a little bit in general about childhood cancer and cancer types, and then move into a little bit of special situations where our dental colleagues are especially helpful, and kind of go from there. So childhood cancer is the leading cause of death by disease outside of infancy. From a numbers standpoint, in 2023, it was estimated that there were 15,000, more than 15,000 children who were diagnosed with cancer, and this is ages 0 to 19. Of those, unfortunately, a near 10% actually do die, so 1,590. And then just there is some difference in types of cancers and the rates of cancers with regards to ages as well. So over 9,000 cases in the younger kids, and then over 5,000 cases in more the teenage group. So you can see, 15,000 children in 2023, whereas there were 288,000 men diagnosed with prostate cancer and 297,000 women diagnosed with breast cancer. So although we take care of lots, it seems like we take care of lots of children with, cancer here, it's still a rare disease compared to adult cancer. And that has implications for, government funding for research and stuff. So there's a lot of money that goes into adult cancer research and not as much that goes into pediatric cancer research. And we obviously try to battle with that and change that as much as we can. So with regards to, what types of cancers do kids get and their incidence, main thing to take away is really the top 3 cancers that kids get, leukemia being by far the most common, and then brain cancer, brain tumors, and then lymphomas, and then a whole number of other cancers. It's kind of interesting that there is a fairly high rate of melanomas and skin cancers in our adolescents. And the little kids don't get those, but the adolescents sometimes do get diagnosed with melanomas, but almost all of theirs are, local and taken care of by dermatologists, and they never end up seeing me. And metastatic melanoma, of course, is exceedingly rare in kids. With regards to our cure rates and survival rates, this is data that's about 5 years old, but still pretty current. So overall, we're at about 86%. You can see it there. And then, our big, kind of, if you want to call them successes, are the acute lymphoblastic leukemias. We have over 90%. Hodgkin lymphomas are well over 90%. A type of kidney cancer called Wilms tumor is again, very curable. And then you can kind of see where our challenges are. So acute myeloid leukemias, which is a subtype of, leukemia, is a little more difficult to treat. Some of the non-Hodgkin lymphomas are more difficult to treat. And then these soft tissue cancers, most of which are called sarcomas, also tend to be much more difficult to treat. And this, a little hard to read here, but these are age groups, and these are the different types of cancers, that most of our children get. And so, you can see from 0 to 4 years old, 5 to 9, 10 to 14, and then the teenagers, 15 to 19 years old. And the main thing I want to point out is just to show that development of childhood cancer is not something that, is static. It changes as you develop and as you get older. And the types of cancers, little kids get is different than the kinds that adolescents get. And so, infants and, little kids, their peak cancers are the kidney cancers. The leukemias are very high in that age group. And then, the brain tumors, whereas in older kids, they tend to get more types called germ cell tumors, and those can be testicular or ovarian cancers in kids. And then some of the brain tumors as well, and other sarcomas that they get in older kids. And, and you can, to link this back to our, dental doubleheader here, it kind of affects what kind of things are going on in these kids' lives depending on their ages. So obviously the little kids who are getting chemotherapy when they're 0 to 4 years old are going to have many more long-term side effects from their chemotherapy on their dental health and dental development. And so those are things we have to think about a lot. And then the teenagers who are getting cancer are kind of worried about how they look. I mean, they're very worried about their hair falling out. They're very worried about, not being able to get braces because they're getting chemotherapy. And so these are all, big issues that, come up that we have to talk to these kids about and their families. So I know Dr. Chen's going to show pictures of her clinic, and this is a picture of our infusion center that's just upstairs on the 3rd floor, right around the corner from the dental clinic. And this is where most of our chemotherapy is given for our kids, and it's kind of, I think, an amazing feat to give some very toxic chemotherapy drugs in a much more comfortable environment than the hospital is. And There are some regimens where we do need to admit patients to the hospital, and the kids need to stay there, usually just, a few days, but there are some types of cancer where they're in there for months at a time. But most of our chemotherapy, we're actually able to give in our infusion clinic upstairs, and they come for the day, and then they go home and are able to sleep in their own beds at night. Like I said, I think it definitely is much more comforting for the family to be able to have that option. This is a study I was going to comment on. This is done about 10, 15 years ago, but this is from a very large group of cancer survivors and looking at the impact of cancer treatment, both radiation and chemotherapy, on the risk of dental abnormalities. This is a table that's kind of small, but I think the biggest set of numbers I want you to look at are these right here. So the odds ratios. And what they're doing is they're comparing survivors with a sibling. So these are comparing, patients and their siblings who got the same type of environment to grow up in, the same type of dental care, and just showing you that the rates of dental abnormalities are nearly 2 times more in the kids who were treated with chemotherapy. And abnormal roots are 3 times more common. Dry mouth xerostomia issues are almost 10 times more common in survivors of childhood cancer. And the need for oral prostheses is almost 4 times greater in patients who were survivors than their matched siblings. So again, just to show you that although we are curing, over 85% of kids with cancer, we're leaving them with, lots of side effects, both dental, endocrine, growth, fertility, and I'm not getting into those here, but again, there are lots of long-term side effects of our therapies that are affecting these children. And then this is another from the same study looking at other determinants of dental health in these populations. And as would be expected, people with higher education had better outcomes. They got their teeth cleaned more. And people who have lower incomes were unable to get to the dentist in the recommended fashion. And I think this just goes to show why a clinic like ours is so unique and so beneficial, because 54% of our kids are, have Medicaid insurance. And although they didn't separate this out by insurance, a lot of the disparities are based on insurance. And a parent that's working 3 jobs cannot take time off to go see the dentist. And so if we can enable them when they're here getting their child's cancer care, allow them to go around the corner and see a dentist to get that routine care done is really valuable, and really the best way to care for that child and their family, and their siblings can go too. And so I like to, use, the definition of medical home, which is generally, a primary care, phenomenon where it's best described as a model of philosophy of primary care that is patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality and safety. And although we're not really primary care, I think we take care of most of these kids for many years at a time. And then for kids with diseases like sickle cell disease or other chronic diseases, we do serve as kind of their primary care providers. And I think being, like I said, in this very multi-specialty clinic that has access to dentistry, has access to physical therapy, neuropsychology, orthopedics, rheumatology now, we're able to really provide this medical home for these families. And I think the model's a really great one, and I think we're really serving our community well with it. And then I was going to go through some kind of special situations just to tell you some of the unique ways in which some kids need to be treated in order to cure their cancer or chronic disease. And it's just kind of interesting. So this is bone marrow transplantation, and we don't do these here yet in Nevada, but we're working to open up a way to do allogeneic or unrelated bone marrow transplantation at our hospitals here in town, and that's a work in progress. But so right now we have to refer these patients out either to Los Angeles or Salt Lake City or Arizona to get these bone marrow transplant procedures done. And one of the requirements of a kid getting a bone marrow transplant, and is they need to be cleared by a dentist and have their teeth looked at very closely. And if they have any active infections or teeth that need removed, we have to get that done pretty quickly. And having access again to our dental colleagues here has made that again just way easier than it used to be. But so what do we use? So again, there's another type of transplant I'll talk about called autologous, where you take your own cells and you give them back to yourself. This is where you're getting bone marrow from another person, and that can be from a sibling or a parent or an unrelated donor. And we use that to treat either relapsed or resistant leukemias, aplastic anemia, certain inherited bone marrow failure syndromes, or even some genetic disorders. And it involves having a donor that you have to match up their bone marrow type. You collect their stem cells, and then those can get frozen down and processed. And then, usually the child has been given lots of chemotherapy for their leukemia, and they actually need to get a little bit more chemotherapy before their bone marrow transplant to empty out their old bone marrow. And then you infuse the stem cells, and you see the infusion of stem cells, it's not a surgery, it's not like a liver transplant. It's actually just like a blood transfusion. So it's not very impressive, but the cells that get infused into the bloodstream actually find their way to the bone marrow and are able to, develop a new home there and hopefully help cure that leukemia as well that we were trying to battle in the first place. And that's kind of how an allogeneic bone marrow transplant works. And that's in contrast to what's called an autologous bone marrow transplant. And we use these to treat kind of a different set of malignancies, usually things like neuroblastoma or brain tumors, certain lymphomas and other solid tumors. And what happens in this case is instead of another person donating the stem cells, you're getting the stem cells from the patient themselves. That's step one. And then, step 2 and 3 are you save those cells and freeze them away. And then again, usually there's kind of a gap between the reinfusion of cells. You're giving them high-dose chemotherapy or other stuff to help treat these cancers. And then after you've given them so much chemotherapy that their bone marrow can't recover, you then rescue them with the bone marrow that you collected. And then that's the end of their therapy at that point. And then of course they have lots of scans and observation after their treatment. So that's autologous bone marrow transplants. And those we actually do over at Summerlin Hospital right now. And we're looking to become a FACT accredited site for doing those. And then the last kind of thing I wanted to comment on is, in addition to malignant diseases, we do take care of a number of benign chronic diseases as well, although benign may not be the right word because these can be very devastating in and of themselves. Sickle cell disease is one of the most common ones we take care of here, and there's a very high incidence of sickle cell disease in our population here. And it's a common inherited blood disorder, affects about 100,000 Americans at any given time. It is associated with people of African descent, but it can be found in many other races and ethnic groups. It is a genetic disease. It involves getting, usually the parents will have what's called the trait, and then together they can give 2 copies of the sickle cell gene to the patient. And at this point, and I'm going to say this is wrong actually now, but the only cure used to be bone marrow transplant or stem cell transplant for sickle cell disease. But I'm going to talk for a sec about gene therapy that's just been FDA approved for sickle cell disease. So patients with sickle cell disease, one of the characteristic features is they have what are called pain crises. And this pain can be, again, devastatingly severe and results in long hospitalizations and lots of pain medicine use. And it's really one of the most difficult things to treat with regards to sickle cell disease. And then they also have a number of other organ damage that happens from this disease as well. And because of that, they actually live, on average 20 years less than, the average person. So again, although, people are living with this disease, it really is a very severe one to have to live with. And so I just wanted to comment on one of the new therapies that has just been approved, and there's only two. This is one of them called Lyfgenia, and I forget the company that makes it, but I assume they're making lots of money on it. But in any case, this is the newest therapy, and it involves putting a new gene into your own stem cells. And so if you remember my autologous stem cell transplant picture, it's basically this, where you take stem cells from the patient's bone marrow or peripheral blood, and then you infuse these cells with the gene editing technology. And then after that's done, you reinfuse them back into the patient. Now, in between 2 and 3, they actually do need to get some chemotherapy. So it's not just like giving the gene therapy, happens just like that. You actually do have to clean out their bone marrow a little bit. So there is actually some chemotherapy given for this benign disease, but it's again to clear out their marrow so these gene edited cells can do their thing. But again, this just came out, and we're looking to establish a gene therapy center here at this clinic in the next 6 to 12 months, and hopefully be able to treat some patients with sickle cell disease with these FDA-approved therapies. There's also gene therapy now available for certain bleeding disorders called hemophilia, and that's another therapeutic approach that we hope to have going here as well. So lots of exciting changes. And then finally, I wanted to just comment, this is kind of a weird slide, but with regards to cancer, to get back to cancer, just something to think about. I told you we cure 86% of our kids who are diagnosed with cancer. The cure rates are still quite a bit less than that for adult cancers. And one of the reasons why we're not curing these cancers is that the cancer, whether it's leukemia or breast cancer or pancreatic cancer or colon cancer, it actually learns and becomes resistant to our therapies. And that can be immunotherapy, that can be targeted therapy, it can be chemotherapy. So, in spite of all the advancements in all those realms, the cancers are still escaping those therapies. And there's actually some literature out there now about looking at cancer as kind of an artificial intelligence. In other words, if you look at ChatGPT or you go to the Sphere and talk to the robots there, those are learning, robots, and cancer seems to learn in a similar way. And so I think, we need to start thinking about it like that, and we need to try to outthink it in some way. But anyway. But again, for our positive outcomes here, this is just a graph of survival over the last, up through 2009 at least, looking at the survival rate for kids with leukemia. So if you go back to 1968, 1970, here was our survival rate for childhood leukemia, less than 10%. And just in the last 50 years, we have brought that all the way up to over 90%. And this, is one of the great successes of, I think medicine in the last 50 years that we've been able to achieve that. And it's only been done through research and clinical trials. And we're a part of this cooperative group called the Children's Oncology Group. And so we have enrolled children on these clinical trials, and every single one of those patients and their families has been a part of this progress in making, our cure rates better. And even an even more happy thing, so that's me. This is an awesome nurse named Jackie who now works at Stanford. And this is a young man named Peyton, and this is at his wedding. He had T-cell leukemia, and we treated him for 3.5 years. And he finished up a couple years ago now and is doing outstanding. And a year after he got off therapy, he proposed and then went on to get married. I was lucky enough to be invited to his wedding. And that, of course, is the most rewarding thing of all. And he probably has better teeth than I do, but in any case. But I will end there. That's my email on our website. And I know I took us to near the end of our time, but yes, and I know I probably don't have time to take questions, but you can email me or ask me anything anytime.
Thank you. We have Dr. Chen, and we have until 7:30, but I don't
Oh,
think we're
good.
going to go that entire time. So we
Okay, great. So I was in private practice for a long time. In 2021, I sold my business and I was at the part of my life where I wasn't really quite sure what I was going to do with the next part of my career. And I saw a interesting job recruitment ad from Roseman University of Health Sciences. They were specifically looking for a pediatric dentist that will work with their medically compromised children at the Cure for the Kids Foundation. And that stood out to me because working with sick kids had always been a passion of mine when I was a student. I didn't get to do a lot of that in my private practice, so I am very proud to stand here today and share that passion with all of you. Thank you, Clark County Credit Union, for the lovely sandwiches. So sick kids have some really, really unique dental characteristics. Higher chances of developing decay. So that is going to be a combination of sugar and home care. Home care referring to brushing and flossing. Kids don't really love brushing. I have 2 kids. They don't like to brush. They have to because their mom is a dentist. But kids who are sick specifically, they are tired. They suffer from nausea and vomiting. A lot of them are depressed because they are not in school. They don't get to see their friends or play outside. And the other part of home care is what the caretakers are doing. So these can be parents, they can be grandparents, juggling among responsibilities such as taking care of the other kids, dealing with school, work, and now we add medical visits, getting labs in and out of hospital. Thinking about teeth and caring about oral care can fall to the bottom of their priorities. Xerostomia is something that Dr. Lasky mentioned earlier. So we're talking about dry mouth and lack of saliva flow. This can be caused by chemotherapy, medications. Radiation in the head and neck region can also cause xerostomia. When we have a lack of saliva flow in our mouth, it's harder for bacteria, sticky things, sugary things, acidic things to get washed away. So we run into a higher susceptibility of developing decay. How many of us have ever had a canker sore in our mouth? Okay, a canker sore, yep. So imagine having 20 to 30 canker sores all at the same time for over 2 to 3 weeks. Yep, so we don't want to eat, we don't want to drink, putting a toothbrush or a dental floss in the mouth, very, very painful. Unfortunately, this is something that a lot of our kids have to go through when they're undergoing chemotherapy. Diet. So a lot of these medications and therapy, it changes their taste sensations and taste buds. Food don't really taste good anymore. And to compensate for that, parents and caretakers a lot of times have to increase the amount of sugar to get them to want to eat so they can stay hydrated and satiated. Kids that we treat also have compromised immune system. So the way chemotherapy and bone marrow transplant drugs work is in addition to killing the fast growing cancer cells, These therapies minimizes our own immune cells, so we are at a higher risk for infection. A lot of these kids have a port that is connected to their system, so that allows for easy blood withdrawal. It allows for easier administration of IV medication, but the downside is that the port themselves can become a source of infection. Dr. Lasky talked about sickle cell anemia earlier. In addition to compounding illnesses, a lot of these sickle cell kids, they have organs removed, such as their spleen, and that compromises their immunity as well. So why are we worried about infection? Dental procedures are associated with what we call transient bacteremia. And what that means is the amount of bacteria in our mouth becomes elevated after any kind of dental or gum manipulation. So when we look at this table, on the top is the baseline. So in a healthy child's mouth, with nothing going on, so no brushing, no flossing, the amount of bacteria is 8%. After we do simple dental polishing, so we're just kind of going around with a polishing paste, a polishing brush, barely touching the gums, the percentage of bacteremia increases to 25%. When we do scaling, so now we're sticking a pretty sharp metal instrument, maybe about 2 to 3 millimeters underneath the gums, percentage raises to 40%. And of course, even after pulling out a single tooth, we have access to the gum and the bone, and the percentage of bacteremia is at 39%. So I wanted to include some photos of what that gum manipulation looks like. So we're just doing a dental filling, sticking kind of a toothpick looking plastic thing in between the teeth, little bit of gingival manipulation. This is what a tooth looks like after we prepare it for a crown. So lots of trauma around the gums. And of course, dental extraction, direct access into the bone area. Dr. Lasky mentioned earlier, a lot of these kids have missing teeth. So what radiation can do is radiation at an early age can just zap out little tooth germs that are supposed to later develop into permanent teeth, and radiation just completely zap them out. So a lot of these kids, when they grow up, they have multiple missing teeth. Bisphosphonates is a class of medication that we pay attention to. When most of us who are in good health have dental surgery, so it could be getting a tooth pulled, it could be getting dental implants, takes a few days, maybe a week or two for bone to heal. People, adults and children who are on long periods of IV bisphosphonates therapy, they are more prone to a condition called osteonecrosis. So instead of the bone healing, it just dies. When it's a small area, we can scrape it away. It's not the end of the earth. But sometimes it involves like half of the mandible, so the jawbone. So now we're talking about aggressive surgical resection, and it's devastating, very, very difficult to treat. So orthodontics and dental implants are topics that we bring up fairly early in our dental conversation with these families. C4K treats a high number of kids with bleeding disorders. So I wanted to include this picture. We're all familiar with what a baby tooth looks like after it falls out. So you have a cute little bloody hole on the gums, bleeds for a couple minutes, no big deal. And then we all get really, really excited about how much Tooth Fairy is going to bring. Now, for a child with bleeding disorder, this is what the parents and the school nurses might have to deal with. So this is obviously very, very emotionally distressing. Children with complicated medical conditions, when they have delayed or absence of dental care, it can delay their medical treatment. It can make them sicker. And those are definitely issues that we have to deal with, and they're very, very difficult, not ideal situations. And they face a lot of barriers, unfortunately. When it comes to barriers, there are non-environmental barriers, and these are listed at the bottom of the slide. So these are barriers that are within the child. And these are barriers that can be hard for the medical professionals to control. We are going to concentrate on environmental factors here today. So how do we find dentists and staff workers who are experienced in treating kids with severe illnesses? What if they're anxious? What if they're just not comfortable doing it? How do we find good appointment times near the house? Insurance is definitely a huge factor too. A lot of kids who are undergoing treatment, they're on Medicaid. They are not necessarily underprivileged. So for a lot of them, they have a private insurance, but because they have these rare diseases, the state offers them Medicaid as a secondary insurance. So they're definitely looking for providers who are within the Medicaid network. So these are the factors that back in 2018, when Roseman University of Health Sciences and Cure for the Kids Foundation formed their official affiliation, what the leadership envisioned was a dental facility that would break down every single one of these barriers. And the fruit of that vision is what brings us back here to the story that we're sharing today. And that is a project that I am so proud and so privileged and honored to be a part of. Right here on the 3rd floor of this building. Our dental clinic opened for patient care in April of 2022. We're community-based and nonprofit, and the clinic is designed specifically to treat kids with special healthcare needs. Thanks to our local donors and dental supply companies, we have top-of-the-art, state-of-the-art technologies, equipment, and supplies. Our faculties and residents from the College of Dental Medicine all participate in the care of our patients here. And we offer services for all ages, including wisdom teeth removal, root canal, dental implants, whatever you can think of. And we have an additional 2nd location in Henderson. These are our providers. You'll recognize Dr. Thacker, who spoke to us earlier about taking care of our dogs on the lower right-hand side. Dr. Sivan Gewelber is sitting right here in the audience. Let's see. So the first part of Roseman Dental Summerlin was limited to pediatric dental care. We offer a full range of behavior management modalities, including nitrous oxide and oral sedation. After about 8 months, we decided to expand our services to our adolescent patients and adults. So then these can be young adults who are being treated in C4K, or they can be parents of the little kiddos that we treat. Comprehensive orthodontic care are provided from faculty and residents with Roseman's orthodontic residency program. And I think what makes such an elevated patient experience is the fact that our services are designed with the foundation of empathy and compassion. And that starts with the initial telephone communication, that phone encounter, when the parents call us to make that first dental appointment for their child. This is Heather. She is one of our business staff, very, very friendly, very, very lovely. So what the parents are expecting when they call us is they're expecting to be bombarded with paperwork. So we want you to bring a full list of medication or tell us over the phone. We want a list of doctors, where you have been. And pleasantly surprised, they are assured by our staff that they don't have to worry about paperwork at all. And we will take care of all of that internally. And all they have to worry about is just showing up to their appointment. As soon as the dental appointment is made, we request the child's health and physical. So this is a little boy that Dr. Lasky and I co-managed recently. He has a bleeding disorder. And this is what that health and physical may look like. And in addition to current illness, past medical history, vitals, medications, this health and physical also has notes about if the child is having issues in school, who are the other family members? Are there any mental anxieties or illnesses that the child is also dealing with? And all of this information contribute into a better understanding between us and the family so we can build a better rapport. And this is reviewed by myself prior to the patient's arrival. So the day when the patient comes, we can focus on teeth. We do an X-ray examination. We do a periodontal, so that's your gum evaluation. We talk about all kinds of fun stuff. Oral hygiene, brushing, flossing, fluoride exposure, orthodontic issues, and of course, we check for cavities too. Okay, I'm gonna go back. So once we have a dental plan, we schedule an appointment, usually a week or two out, and we dismiss the patients. And again, oftentimes the parents are like, oh, are you going to give me a paper? Do I need to bring anything to my doctor? And we say, no, don't worry about anything. So the patient leaves, and I put together a medical consultation, and this is what that looks like. So this little boy, he has 8 baby teeth with cavities. I am planning on treating him over 2 separate appointments with local anesthesia and nitrous oxide. 3 of the teeth, the cavities are a little bit bigger, so he might need some stainless steel crowns. I'm asking Dr. Lasky, do I need to modify anything in my plan? Are there any contraindications? So what makes it so nice to be in my shoes is that Dr. Lasky and his medical team always gets this letter and the consultation, an answer to the consultation letter back to me within 24 to 48 hours. There is not a single pediatric provider in town that will do that for us. So I really appreciate that. So in the case of this patient, it was Dr. Ford who got back to me. So this little boy needs some oral medication starting the night before the dental procedure, continuing for a few days after. As soon as I get the physician recommendation, I get back on the phone, I'm calling mom, and we go over what the doctor is recommending. If we want to make sure that they have this medication in stock, if not, we call it in and make sure they're well stocked and have a good supply. And if they have any questions about the dental treatment itself, this is also a great opportunity to kind of just iron out all questions so we're on the same page. So the patient comes in, we do the dental procedure, and then after the treatment, I write a report to Cure for the Kids Foundation, just kind of summarizing how things went, what to look for at the next visit. And this report gets filed into the child C4K chart. So all the medical providers can stay on the same page. And all these things are kind of done behind the scenes. We try to not impose on the parents' time with any of these internal communications. As of today, hundreds of C4K patients and their family members have been provided a dental home. Our schedules are full, but they're never packed. And that means if somebody needs a quick clearance, a quick consultation to be cleared for bone marrow transplant, we can get them in same day or the next day. We can even do some treatments on the same day. All patients 7 age and above receive orthodontic screening. And if they need to start braces early, we make that referral too. The faculties, we participate in comprehensive clinic in C4K's facility. Some of the big projects that we're looking for in the next few years is we are looking to expand our dental services under general anesthesia. I recently got credentialed to provide that service in UMC, so most likely we're going to be doing that there. And the next step is just to come up with the funding to purchase all the equipment. Right now, comprehensive orthodontic services, so full braces, these types of treatments are offered in our Henderson location. So we want to provide that in our Summerlin location too. And of course, as a premier education facility, we want to be able to bring more of our dental students and dental residents to participate in the care of these patients, so they themselves can learn how to become better providers for their own patients in the future. And I wanted to conclude my presentation with a few kind words from two families that we have been working with.
Any questions? Run it up to you.
I was just wondering what you've been doing in the meantime before having access to general anesthesia. Were you having to refer some patients out somewhere?
So in the past, I've been here for almost 2 years. I think we have referred about just 4 or 5 patients out, and I referred them out to the UNLV Pediatric Dental Residency.
Okay.
And then, but the majority of our patients is just oral sedation, lots of talking, a lot of verbal behavior management. I'm probably on the very, very conservative side when it comes to sedating and medicating kids. So I really just prefer to talk them through it. I also think learning how to cope with the dental situation and being in a medical environment helps them kind of overcome some of their fears. When you put them to sleep, it's not really a learning experience. They wake up, they're still scared. If we can talk them through it, I feel like they have a higher chance of not being afraid of the dentist when they're older.
Right. So the ones that you have referred, were they some of the youngest ones?
They were. So the last one that I referred, she was only 3. They were recent immigrants to our country. She had some kind of cancer. I can't remember exactly what type of cancer, but it was in her brain. And she basically needed 12 crowns in her mouth. So it definitely wasn't something that I can provide in the office.
Right.
Mhm.
Okay. Thank you.
Also, with how highly specialized this care is, and it must take more time to have visits with some of these patients, is also, to me, how outstanding it is that our dental clinics are reduced cost. Our orthodontia is up to 50% off of other standard practices. And so it's really pretty amazing to me that we can offer this level of care at a reduced cost to our patients.
I agree. And Vanessa, who has been with the university for a very long time, can probably tell us more about, how like that initial vision was formed, like whose idea was it?
Well, I think you told the story exactly as it was, which
Okay.
is, there were some very clear barriers, and we had some empty space in this building. We were very happy to have just formed our partnership with Cure for the Kids, and Cure for the Kids has such an incredible, surround care for their patients. And so adding on the pediatric dentistry was just yet another incredible thing that they could offer, and it was very beneficial to us too. And if you think about the extension then that the clinic offered to serving adults, many of these families are here treating their kids, and to get an infusion, these things take hours. They're sitting here for hours. And so if you could think about making their time more efficient, these families, while they're waiting for their children to be treated, that is another incredible thing, because Lord knows when they leave here after having their child be treated, the last thing they want to do is care for themselves. They don't have time, they're tired, and all those things. So I think the next thing we need is like a hair salon and a nail salon.
Well, I mean, for myself and all our dental colleagues, we're really, really excited and happy to be here. So, yeah.
Well, thank you for those of you that have stuck with us tonight. I am incredibly proud of our 3 presenters and of these programs. And so this is really just a great night to be able to celebrate them and all their good work. So please give me, if we can cheer for Dr. Chen, I'd appreciate it.